Hey, Pediatric team, let's get to the heart of it. Today we're doing a deep dive into the really complex world of pediatric cardiovascular conditions. We've got a whole stack of sources here, and our mission is to really unpack the key stuff they provide. We're going to focus on understanding congenital heart defects, and getting better at recognizing those sometimes tricky signs of poor perfusion, and of course, learning about the crucial nursing interventions highlighted in these materials.
That's right. Think of this deep dive as, well, your focus, look at what these sources say on these critical topics. We're going to pull out the essential info, maybe cut through some of the, density you find in text, and really highlight what's most important for building that solid foundation of understanding and doing it efficiently.
Okay, let's get into it. Our sources kick things off with the basics. The pediatric heart itself, it sits right there, center of the chest, about the size of the child's own fist. What strikes me right away is how dynamic it is. The heart rate changes so much with age, right? Anywhere from, 60 up to 160 beats per minute.
Exactly, depending on the age. But here's something interesting the sources point out. Despite the size difference and rate changes, a child's heart actually pumps just as hard as an adult's when it needs to. Quite powerful.
Wow. Okay. And the anatomy?
Oh, it's beautifully intricate. You've got the four chambers, right and left atria up top, receiving blood, and then the right and left ventricles below, doing the pumping out.
And the valves are key.
Absolutely critical. Four main ones. Tricuspid, mitral, also called bicuspid aortic, and pulmonic. The core idea here, they're like perfect one-way doors. They have to prevent blood from flowing backward. That's essential for efficient circulation.
Okay, so let's trace the path. Deoxygenated blood, the used stuff from the body, comes back through the vena cava into the right atrium.
Precisely. From the right atrium, it passes through that tricuspid valve into the right ventricle.
Right ventricle's job.
Pump that deoxygenated blood through the pulmonic valve into the pulmonary artery and straight off to the lungs.
Lungs are the pit stop for oxygen.
The essential pit stop. Once it's loaded up with oxygen there, the blood comes back through the pulmonary veins. It enters the left atrium, then goes through the mitral valve into the left ventricle.
The powerhouse.
Absolutely the main engine. That left ventricle then pumps the fresh oxygenated blood out through the aortic valve into the aorta. And the aorta takes it everywhere else in the body.
Okay, that's the standard flow after birth. But the sources really emphasize how different it is before birth. Fetal circulation. This is where it gets fascinating. Lungs aren't doing the breathing work.
Right, the placenta handles respiration. So the sources say something pretty amazing. About 90% of the blood actually bypasses the lungs while the baby is in utero.
How does it do that?
Through two temporary fetal structure shunts, really. One is the foramen ovale. It's a little opening between the right and left atria. The other is the ductus arteriosus. That's a vessel connecting the pulmonary artery directly over to the aorta.
So it shortcuts the lungs.
Exactly. It lets blood go pretty much straight from the right side of the heart out to the body, skipping that whole lung circuit because it's not needed yet.
And then at birth, boom, big change.
Huge transition. That first breath is incredible. The lungs inflate, resistance in the pulmonary vessels just plummets. And ideally, those two shunts, the PFO and the PDA, they close up pretty quickly.
That transition is so critical, isn't it? Because the sources explain that a lot of congenital heart problems happen when these structures don't close right or other parts didn't form correctly in the first place.
Exactly. And the sources categorize these heart defects broadly. You've got congenital and you've got acquired.
Congenital means born with it. These are structural issues from fetal development. The numbers cited are around 6 to 8 per 1,000 live births. So something like 40,000 babies a year in the U.S.
That's the scale. And a key point here is the cause. Genetics definitely play a role, maybe up to a quarter of cases, according to the sources, but many others are complex, multifactorial, or sometimes the cause just isn't known.
And acquired.
Acquired heart disease develops later, maybe in a child born with a normal heart, or sometimes it complicates an existing defect. The sources mention things like infections, autoimmune issues, or exposure to teratogens, harmful substances during pregnancy as possible causes.
Okay, let's talk about a sign we often associate with heart issues. Cyanosis. That blue tinge. Why does it happen? What's it really telling us?
Well, the sources explain cyanosis is basically visible evidence of not enough oxygen in the blood reaching the tissues. It could be because not enough blood is getting to the lungs to pick up oxygen in the first place.
Or maybe oxygenated and deoxygenated blood are mixing when they shouldn't.
Exactly. That's another major cause. But here's a crucial point. You often won't see cyanosis until the oxygen saturation drops quite a bit, maybe down to 85% or even lower, especially if hemoglobin levels are normal.
So not seeing blue doesn't mean everything's fine.
Definitely not. But seeing central cyanosis around the mouth on the trunk, that is always an abnormal finding. It needs immediate attention.
Got it. The sources then get into classifying congenital defects based on blood flow patterns. First up, increased pulmonary blood flow.
Right. These usually involve some kind of abnormal connection, think holes between chambers or vessels that shouldn't be connected after birth. This connection lets blood shunt or flow from the higher pressure left side of the heart over to the lower pressure right side.
So too much blood ends up going to the lungs.
Precisely. Overloads the pulmonary circuit. Examples given are PDA, that patent ductus arteriosus we mentioned if it stays open. Also ASD, atrial septal defect, a hole between the atria.
Yeah.
And VSD, ventricular septal defect, a hole between the ventricles.
Okay, next category. Decreased pulmonary blood flow.
Here, the core issue is usually some kind of obstruction that limits blood flow out of the right side towards the lungs. So blood can't easily go where it's supposed to. It gets backed up, pressure builds on the right side.
And it's forced to go somewhere else.
Exactly. It often shunts across a defect, like a VSD, from the right side directly over to the left side. This means deoxygenated blood enters the systemic circulation, bypassing the lungs. That's what causes significant cyanosis.
Makes sense. Examples.
Classic ones mentioned are Tetralogy of Fallot, or TOF, also tricuspid atresia, where the tricuspid valve just doesn't form properly, and Eisenmenger syndrome, which is actually a late complication from long-term left to right, shunts that reverse.
Then there are the obstructive disorders. Pretty self-explanatory name.
Yep, something is narrowed, creating a blockage to blood flow leaving the heart or within a major vessel. This makes the heart chamber before the obstruction work much harder. Examples include coarctation of the aorta, COA, a narrowing in the aorta, aortic stenosis, AS, narrowing of the aortic valve, pulmonary stenosis, PS, narrowing of the pulmonic valve, and pulmonary atresia, PA, where the pulmonic valve is completely blocked or absent.
And the last category, mixed disorders. Sounds complicated.
They often are quite complex. Here, oxygenated and deoxygenated blood get significantly mixed within the heart or the great arteries. The normal separate pathways for pulmonary and systemic circulation are just not there. This leads to desaturation systemically and often issues with cardiac output too.
Examples.
Things like transposition of the great vessels, TGV, where the aorta and pulmonary artery are basically switched. Truncus arteriosus, where only one big vessel leaves the heart instead of two. Total anomalous pulmonary venous return, TAPVR, where the lung veins drain back to the wrong side. Hypoplastic left heart syndrome, HLHS, a severely underdeveloped left side. And Ebstein's anomaly, a specific tricuspid valve defect.
Wow, okay. That's quite the landscape of defects. It really underscores why assessment is so critical, especially since, as the sources warn, symptoms can be vague or even absent initially.
Absolutely, and that's why our really sharp, focused assessment is vital. The key insight is looking for those specific, sometimes subtle signs the sources highlight. They might be your only early clue.
Where do you start? History.
History is crucial. Family history of heart issues. Any red flags during pregnancy, like maternal diabetes, infections, and then really dig into the baby's story. How's feeding, gaining weight, hitting developmental milestones? Do they sweat a lot, especially with feeding diaphoresis?
Respiratory status, too.
Definitely. How are they breathing? Any history of frequent respiratory infections? Chest pain is mentioned, but sources say it's less common in kids with congenital defects, though you might see it in acquired conditions like Kawasaki disease.
Physical exam, one of the big red flags.
Failure to thrive, poor weight gain, being small for gestational age, the sources link these strongly to potential heart issues.
Other visible signs.
Sometimes dysmorphic features or developmental delays, these can be part of syndromes associated with heart defects. Chest wall deformities might suggest an enlarged heart. And in older kids with chronic cyanosis, you might see clubbing, that rounding and thickening of the nail beds. It's a sign of long-term low oxygen.
Polycythemia came up too. The body making extra red blood cells.
Right, it's the body trying to compensate for low oxygen by increasing the oxygen carrying capacity. But here's the critical insight. More red cells make the blood thicker, more viscous. And the sources warn this can actually impair tissue perfusion and significantly increase the risk for things like stroke or clots. It's a double-edged sword.
Respiratory assessment.
Yeah.
What are we listening and looking for?
Rapid breathing, the sources flag over 60 breaths per minute in a calm infant as concerning. Retractions, pulling in of the skin between ribs or at the neck, any difficulty breathing, especially with exertion like feeding or crying.
Signs of fluid overload in the lungs, pulmonary edema.
Yes, watch for increased work of breathing, maybe grunting sounds, nasal flaring. The sources also mention the hyperoxia test giving 100% oxygen as a way to help differentiate if cyanosis is mainly cardiac or respiratory in origin.
Okay, let's really zero in on that cardiovascular assessment, focusing on perfusion. Basic alertness, activity, tone, those are the initial clues, right?
Vital first indicators. Then, capillary refill. It's simple but so informative. The sources suggest checking centrally sternum or forehead, especially in babies. Normal is quick, less than 3 seconds.
And if it's longer?
Prolonged refill, more than 3 seconds, is a major red flag. It strongly suggests poor cardiac output and poor tissue perfusion.
Pulse is checking everywhere.
Absolutely crucial. Feel radial, brachial, femoral, pedal pulses, rate their strength or volume, and compare right versus left, upper versus lower extremities. They should feel equal.
What if they're not equal?
Big diagnostic clues there. Bounding pulses in the arms, but weak or absent pulses in the legs. That screams coarctation of the aorta. Generally, bounding pulses everywhere might mean high blood pressure, fluid overload, or maybe a large PDA.
And weak pulses.
Weak, thready, or difficult to find pulses suggest poor cardiac output, maybe shock or severe obstructive lesions. Very concerning.
Extremity temperature, another quick check.
Yeah, after those first few hours of life, persistently cold hands and feet compared to the trunk can indicate the body is shunting blood centrally. Another sign of poor perfusion.
Blood pressure. Getting it right is key.
It is. Use the right cuff size sources, say about 25% wider than the limb circumference. Approach matters too. Keep it non-threatening for the child. Normal values vary with age and size. A useful rule of thumb mentioned for older kids is minimum systolic BP should be around 70 plus twice their age in years.
Pulse pressure matters too.
Definitely. Wide pulse pressure, a big gap between systolic and diastolic, often with low diastolic, might suggest a PDA. Narrow pulse pressure to low systolic, relatively high diastolic can indicate poor cardiac output or even shock.
And the forelimb BPs.
Sources strongly recommend this if you suspect heart disease. A difference of more than, say, 20 millimeter Hg with upper BPs higher than lower BPs is a classic sign pointing towards an aortic arch issue like COA.
Other things to look for: neck veins, liver size.
Yep. Check for distended or pulsating neck veins warrants investigation. And hepatomegaly, feeling the liver edge more than 3 centimeters below the ribs on the right side, is a significant sign. It suggests increased pressure on the right side of the heart, often seen in congestive heart failure, CHF.
Color assessment, it's more than just blue, right?
Absolutely. Central cyanosis, blue lips, tongue, trunk is always abnormal. But distinguish it from peripheral cyanosis or acrocyanosis, blue hands and feet, which can be normal in newborns. Also remember, anemia can mask cyanosis, while polycythemia can make it look worse than the actual saturation level might suggest.
So look for other color changes too.
Yes. Pallor, unusual paleness modeling, or a dusky gray appearance are also really critical indicators of poor perfusion.
And urine output. Can't forget the kidneys.
Never. Kidneys need good blood flow. Decreased or absent urine output is a major sign of poor perfusion, potentially shock. It tells you the kidneys aren't getting what they need.
Cardiac auscultation, listening to the heart. What are the key things?
It takes practice, but you're listening for the basic heart sounds, S1 and S2. Are they clear? Any extra sounds like splits, clicks, or gallops. Where's the PMI, the point of maximal impulse? Does it feel normal? Listen for the rhythm too fast, tachycardia, too slow, bradycardia, and then murmurs.
Murmurs mean turbulent blood flow.
Exactly. You need to describe their intensity, location, timing, and the cycle. While some murmurs are innocent, the sources emphasize that murmurs heard during diastole, when the heart relaxes, or that are continuous throughout the cycle are almost always pathological. Need follow-up.
The sources also talk about the critical congenital heart defect or CCHD screening. That's standard now, right?
It is, thankfully. Using pulse oximetry on newborns after 24 hours of age, you check oxygen saturation in the right hand, that's preductal blood, and 1 foot, postductal blood.
And there are specific pass-fail criteria.
Yes, based on the saturation levels and the difference between the hand and foot readings. A reading below 90% is an automatic fail. Getting 95% or more in both with less than a 3% difference is a pass. The crucial insight. This simple screen helps catch 7 major critical heart defects like HLHS, TGA, Tetralogy of Fallot before the baby gets really sick. Early detection saves lives.
Okay, let's connect this to a few specific defects. How does this assessment play out with, say, patent ductus arteriosus PDA?
Right, the PDA, that open fetal vessel. Assessment-wise, the classic sign is often that murmur, sometimes described as a continuous washing machine sound, though it might be absent in preemies or if there are complications. Beyond the murmur, you look for signs of that increased pulmonary blood flow we talked about, so maybe wet-sounding breath sounds, crackles to chypnea, increased work of breathing, maybe even apnea spells.
Feeding problems, too.
Often, yes. Poor feeding, poor weight gain, tiring easily, sweating with feeds, signs of fluid overload,
And the diagnostic signs mentioned.
wide pulse pressures, bounding pulses, maybe poor SpO2, prolonged cap refill. If it's a large PDA causing strain, you might see an enlarged heart on chest x-ray.
Nursing interventions for PDA.
Focus is managing that extra lung blood flow and supporting the heart. So decreasing work of breathing, maybe smaller, more frequent feeds, ensuring rest, not clustering all care at once.
Yes.
Fluid management is key. Restrictions, diuretics. Medications might include indomethacin or ibuprofen, which can help close the duct medically. Sometimes dopamine or digoxin are needed for heart support. And then there's post-op care if it's closed with a coil in the cath lab or surgically tied off. Monitoring urine output, labs, daily weights, feeding tolerance, all crucial.
Caregiver education.
Teaching them to monitor intake output, watch for irritability or lethargy, importance of follow-up, how to give diuretics, and importantly, preventing bacterial endocarditis later on.
Okay, how about Tetralogy of Fallot TOF?
Yeah.
That's a decreased pulmonary flow defect.
Right, classic right-to-left shunting defect. The big thing with TOF assessment is recognizing and knowing how to manage TET spells.
Those sudden blue spells.
Yeah, exactly. Sudden, severe cyanosis, maybe fainting, extreme distress. It's a hypoxic event. The key thing caregivers must learn is the knees to chest position. It increases systemic resistance, helping push more blood towards the lungs.
Other assessment findings for TOF.
Baseline cyanosis, how blue they are, depends on how severe the pulmonary stenosis is. Irritability, maybe clubbing over time, poor growth. Clinically, you might hear a murmur, could be soft or loud. They might faint, get short of breath easily with activity, develop polycythemia. The chest x-ray often shows that characteristic boot-shaped heart.
Nursing interventions for TOF.
Aim is to improve oxygenation and prevent those TET spills. So, promoting rest is key here. Clustering care might be better to allow longer rest periods. Sedation, maybe morphine, can help reduce agitation, which triggers spells. Careful fluid balance. Oxygen is given, but you need to understand it won't fix the saturation if the blood isn't getting to the lungs. It mostly helps reduce pulmonary vasoconstriction. Sometimes vasopressors are needed to increase systemic pressure. Prostaglandin E1 might be used initially to keep the PDA open for extra pulmonary blood flow before surgery.
And surgery is usually needed.
Yes, TOF requires surgical repair, often in stages. Patching the VSD, relieving the pulmonary stenosis, maybe a temporary shunt like a Blalock Taussig first.
So caregiver education is huge.
Absolutely. Teaching the TET spell management, knees to chest, understanding activity limits, and stressing that this requires lifelong cardiology care even after repair.
One more specific example, coarctation of the aorta, COA, the obstructive one.
Yep, that narrowing of the aorta. Sources warn it can be sneaky. Infants might seem okay until the ductus arteriosus closes, then they can crash quickly with heart failure signs. In older kids or teens, it might present as just high blood pressure.
Assessment keys for COA.
You might hear a systolic murmur, but the absolute critical finding is often in the pulses and BPs. Weak or absent femoral pulses compared to strong, maybe bounding pulses in the arms.
And that blood pressure difference.
That forelimb BP check is essential. Finding upper extremity BP significantly higher, like 10, 15, 20 millimeter Hg or more than lower extremity BP, is highly suggestive. Other signs in infants could be poor feeding, poor growth, signs of CHF. In older kids, maybe headaches or leg cramps with exercise. Chest x-ray might show that 3 sign or rib notching.
Nursing interventions.
Close monitoring for CHF, administering meds like digoxin or diuretics if needed, meticulous perfusion checks, and consistently getting those forelimb BPs. Plus, managing care before and after repair, whether it's done via cardiac cath with a balloon stent or surgical resection.
Caregiver education for COA.
Importance of regular BP monitoring, maybe monthly. Understanding potential activity restrictions, and again, that need for bacterial endocarditis prevention throughout life.
Okay, besides these specific congenital defects, the sources briefly touch on some important acquired conditions too.
Yes, good to be aware of those. Cardiomyopathy disease of the heart muscle itself. Can be dilated, hypertrophic, restrictive, leads to failure, arrhythmias. It's a major reason for heart transplants in kids. Congestive heart failure, CHF, comes up a lot. It's often the result of other conditions where the heart just can't keep up with the body's demands.
Hyperlipidemia and hypertension.
Increasingly seen in kids, high cholesterol, high blood pressure. Big risk factors for future cardiovascular disease, so screening and management, often lifestyle-based initially, are important.
Rheumatic heart disease.
Still a concern, especially globally. It's an inflammatory reaction after a strep A infection like strep throat that can damage heart valves permanently. Prompt antibiotic treatment for strep is key prevention.
And subacute bacterial endocarditis, SBE.
An infection of the heart's inner lining or valves. Kids with existing heart defects or valve damage are at higher risk, especially after procedures like dental work. Sources mention specific signs like Roth spots, Janeway lesions, Osler nodes, requires intensive antibiotics. This is why prophylactic antibiotics are sometimes given before procedures for high-risk kids.
Kawasaki disease also gets a mention.
Yes, it's highlighted as the leading cause of acquired heart disease in children in developed nations. It's a multi-system inflammation, and the big worry is coronary artery aneurysms. Diagnosis involves that persistent high fever plus specific criteria like conjunctivitis, rash, lymph node swelling, changes in mouth-lips extremities. Treatment with IVG and aspirin is critical.
The sources also list key diagnostic tests and procedures. Just briefly, what's the purpose of each?
Okay, quick rundown. Chest x-ray gives you heart size, shape, and a look at pulmonary blood flow, vascular markings. Blood gases, ABGS, VBGs. Check oxygenation, ventilation, acid-base status. Critical for sick kids. Electrocardiogram looks at the heart's electrical activity. Good for rhythms, chamber enlargement patterns. Echocardiogram. Echo, that's the cardiac ultrasound. Absolutely fundamental. Shows structure, valve function, blood flow patterns, measures chamber sizes, estimates function, non-invasive.
More invasive ones, angiography, cardiac cath.
Right. Cardiac catheterization is invasive. A catheter is threaded into the heart, allows direct pressure measurements inside chambers and vessels. You can inject dye, angiography, to visualize structures and flow precisely. And importantly, you can often do interventions during TAF, like balloon, open a narrow valve, valvuloplasty, or close a hole. Sometimes biopsies are taken, like after transplant, to check for rejection.
Myocardial biopsy, PA banding.
Biopsy is taking a tiny piece of heart muscle, usually via cath, mainly for transplant rejection surveillance. Pulmonary artery banding is a palliative surgery, puts a band around the pulmonary artery to restrict flow to the lungs in certain complex defects where there's too much flow, often as a bridge to later repair.
So, bringing it all together, what are the core nursing intervention principles highlighted in the sources for these kids?
It boils down to meticulous monitoring, promoting balance, and supporting the child and family. So constant vigilance with vital signs, HR, RR, SpO2, and those crucial BPs. Strict intake and output, daily weights that's non-negotiable for tracking fluid status.
Promoting oxygenation.
Yes, through positioning, ensuring adequate rest periods, minimizing oxygen demands, using oxygen appropriately when ordered. Medication administration is huge. Digoxin, diuretics, ACE inhibitors, prostaglandins, maybe anticoagulants. Knowing the actions, side effects, and signs of toxicity is vital.
Pain management. Pre-post-op care.
Essential. Managing pain effectively reduces stress on the heart. Expert pre- and post-procedure or surgical care is critical for recovery, and preventing infection is always a priority, including that endocarditis prophylaxis when indicated.
And finally, caregiver education. Sounds like a massive piece.
It absolutely is. These families are managing complex conditions, often for a lifetime. Education has to be ongoing. Key areas from the sources. Teaching medication administration, especially tricky ones like digoxin, understanding doses, side effects, when to hold. Helping them recognize signs and symptoms of worsening CHF, increased cyanosis, respiratory distress, infection, or rejection post-transplant. Knowing when to call for help.
Activity restrictions.
Yeah.
Long-term care.
Yes, explaining any activity limits clearly. Stressing the absolute necessity of lifelong cardiology follow-up, even if the child seems well. Helping them navigate the transition to adult congenital heart care eventually. Reinforcing endocarditis prevention for dental or other procedures. And acknowledging and addressing the huge emotional and psychosocial needs of the child and the whole family. Providing resources and support.
So we've really taken a deep dive into these sources on pediatric cardiovascular conditions. We've covered the basic anatomy and flow, looked at the different congenital and acquired defects, really focused on honing those assessment skills to spot poor perfusion signs, and outlined the essential nursing care and caregiver education points from the material.
Right. Understanding these fundamentals, knowing what to look for those key signs of perfusion, it's just so incredibly important in pediatric care. These sources really emphasize that. Vigilance, strong assessment skills, and solid foundational knowledge are your best allies. Hopefully, this deep dive gives you a strong starting point based on this information.
Keep the rhythm strong. See you in the next one.